Thank you very much. So today I've entitled my presentation, The Fundamentals of Interpretation with CEUS. And so I have some disclosures, equipment support, and a research grant from Lantheus Medical Imaging. So the approval indication for contrast-enhanced ultrasound is liver mass characterization, and this has been the worldwide approval indication. And so this answers the question, what is it? Additionally, there is another question about liver mass detection, which answers the question, is it there? And so, of course, we're going to focus on the first of these, although it is inevitable that we will improve our detection of liver masses as well. So the algorithms for diagnosis of focal liver masses on CEUS are similar to those for the non-invasive diagnosis of liver masses on CT and MR scan. And these are based on enhancement characteristics in the arterial and the portal venous delayed phase. CEUS has the unique advantage also of temporal resolution and also exquisite vessel morphology. So the objective of this talk is going to be to highlight the fundamental principles for interpretation of liver masses on CEUS. And we're trying to, first of all, determine which masses are malignant, and then to establish their specific diagnoses. So this presentation is very basic, but I selected it because of the timing at the SRU when this microbubbles have been approved for just over a year. And although I hope that this talk is not too elementary for some of you, I hope that many of you are going to start to do CEUS in your departments or have just started. And so this is really what you need to know to interpret these masses. So I've called these ultrasound pearls. So what's pearl number one? Well, first of all, we want to determine malignancy. And so this is largely based on the observation of the lesional enhancement in the portal venous and late phase relative to the liver, with the recognition that washout has a strong association with malignant outcome. So if we look at a patient and do a contrast-enhanced ultrasound and CT scan, you can see concordance of the imaging in the arterial phase with a hypervascular scar neoplasm. And then if we look into the delayed or late phase, we can see that both of these lesions show washout. And so these lesions are concordant on the two imaging modalities, and the interpretation regarding the state of malignancy or benignancy would be the same. So the washout suggests that these are malignant lesions. So compare these with an asymptomatic female who has both CT and CEUS as well, where we see a uniformly hyper-enhancing mass in the arterial phase. And then when we go to the portal venous phase, we can see that there is sustained enhancement so that the lesion's isovascular on the CT and still remains hypervascular relative to the liver with a non-enhancing scar on CEUS. And so this sustained enhancement, of course, suggests that this will be benign, and you recognize that this is a classic focal nodular hyperplasia. Now, pearl number two. So benign tumors on CEUS are characterized by very specific vascular and filling patterns in the arterial phase. And these are optimally shown on real-time dynamic CEUS. And when I start showing these, you'll recognize that many of these do not show these specific vascular patterns on CT or MR scan. So if we look at the algorithm that Peter Burns and I published back in 2006, if I include just these three common benign lesions, you can see that the gray column in the arterial phase has got little pictures of the specific features that we're looking for. And so what's important about this? Well, when we do dynamic real-time ultrasound with CEUS, we're looking for these specific patterns. Now, we always go on to image the lesions further because we must confirm what the lesion does for confirmation by showing its enhancement in the portal venous phase. And you can see there that those white circles almost completely covering every lesion. And of course, there's one small gray box at the bottom for adenoma. And what's the importance of that? Well, there are always exceptions in all the rules we set for ourselves. And of course, with imaging of adenomas on both CT, MR, and on CEUS, we're familiar with the fact that a good proportion of these lesions will show weak washout. But nonetheless, the fact that these lesions have this specific arterial phase features and this tendency to sustained enhancement really helps us to be exceptionally accurate for characterizing these benign lesions. And what's the importance of this? Of course, when you're looking in your department and you see all the incidental masses that come through, many of them will be benign. So let's look at these quickly. So hemangiomas, we know they're characterized in the arterial phase by peripheral nodular enhancement, which tends to show centripetal progression of the enhancement in either the arterial or the portal venous phase, and have a tendency to sustained enhancement. So here's a patient. This was a patient, a young person who came in with a massive pulmonary embolism. On the CT scan performed for the pulmonary embolism, a large mass was incidentally noted in the liver. The clinicians instantly thought this patient might have malignancy with clotting problems, and so asked us if we could confirm the nature of this mass. And to their surprise, we show at 8 seconds a peripheral rim of enhancement, at 20 seconds centripetal progression of peripheral puddles, and at 1 minute virtually complete enhancement of the mass, a classic hemangioma, which showed sustained enhancement. Now here, a patient who's at risk for hepatocellular carcinoma, a female with HBV. You can see a mass, a hypoechoic ring shadowing looking lesion on the baseline. You can see our images at 11, 20, and 20 seconds. And then at 4 minutes, a classic hemangioma. And here this deep lesion showing these peripheral puddles with the centripetal progression of the enhancement towards the center of the mass. So this advantages of CEUS are really exemplified by this other at-risk patient, where, first of all, a CT scan shows a small mass which is hyperenhancing with no washout on CT. So in an at-risk patient, this remains an indeterminate lesion. And on MR scan, we show the same hyperenhancing mass with no washout. So this patient comes for CEUS, and we confirm that the liver is cirrhotic. We show a focal mass lesion in segment 2 corresponding with the CT and MR abnormalities. We confirm always the cirrhosis with elastography, and there, when we are using bubble tracking technique, we can see that this is definitely a lesion which has peripheral puddles and rapidly fills to the center, and confirm unquestionably that this is a flash-filling hemangioma. And we back up within that clip and can extract these really exquisite images showing the enhancement pattern of this benign lesion. Now, what about this patient? Another one with an oncology history. So recently diagnosed brain tumor, has a CT scan which shows an unusual exophytic mass, which was unexpected, and the patient was sent for ultrasound. So this mass is quite indeterminate on the baseline ultrasound as well. However, when we do contrast-enhanced ultrasound, you can see the beautiful peripheral puddles of enhancement which are progressing centripetally. This is the one lesion where we tend to move around a bit to enhance our capability to show the peripheral puddles. And so we can again extract these excellent images showing those peripheral puddles progressing towards centripetal and ultimately complete enhancement, a classic hemangioma. Now, focal nodular hyperplasia was nicely touched on by Deb Rubens. Now, here we have this stellate vascularity with the centrifugal filling. And of course, we were looking for that portal venous phase sustained enhancement, often with that unenhanced scar. Now, have I ever seen an HCC with stellate vascularity? You bet you, I have. And so this portal venous imaging, which is only available when we do contrast injection is essential. So here's a 29-year-old asymptomatic woman with an unusual exophytic mass lesion, isoechoic to the liver. When we do our contrast injection, as I've said to you, we're looking always for that specific enhancement pattern in the arterial phase. And here with the bubble tracking techniques, which are available on virtually all equipment today, we can see those beautiful stellate vessels radiating from the center to the periphery, giving us an appearance that the mass becomes larger with time. Again, we can extract these exquisite images from the contrast clip. Now, pearl number 3 is that benign tumors generally show sustained enhancement in the portal venous and late phase. Why does this have to be its own pearl? Because of the exception. So the exception to the sustained enhancement is for hepatic adenomas. And we know that a certain small but definite percentage will show weak and late washout. And so these lesions are hypervascular, but it is our impression that they're much less hypervascular than FNH. They can have a diffuse or chaotic vascular pattern, but if they do show a pattern, it will have centripetal filling. In the portal venous phase, they can be variable, and up to 1/2 of lesions in different series that we've done have shown washout. So here we have a 25-year-old female with 6 months of right upper quadrant pain with an indeterminate CT and MR scan. We show a fatty liver with a well-defined hypoechoic mass. When we do the contrast injection, you can see that the mass is hypervascular, but not nice and homogeneous like that FNH, but still a hypervascular mass. And when we look at the images that we take over the course of the examination, at 3 minutes, there is no doubt that this lesion is washing out. So because of our rule about washout, recognizing even that this patient may be at risk for adenoma, we would recommend biopsy or referral for surgical consult. So let's just look at these beautiful pictures on 3 different patients showing benign tumors. So the upper right lesion is obviously the easiest of them all, where we can see that bubble tracking technique showing the stellate vascularity and the centrifugal filling. The lesion on the bottom with the peripheral puddles proceeding to the center of the lesion, and the lesion on the bottom left showing a centripetally filling mass lesion from the periphery to the center with a more chaotic vascular pattern. So pearl number 4, arterial phase enhancement features, which we have just been talking about, so specific for benign lesions, do not really distinguish metastatic lesions at all. And so what is the feature that we're really looking for? We're looking for washout that is most often rapid and marked as the hallmark feature of metastatic tumors. So when we look at our schematic again, so there's our metastatic lesions, and you can see our gray bar, including the appearances that can occur in the arterial phase. So these lesions can really have any pattern. They can be rim enhancing, hypervascular, or they can be hypovascular in the arterial phase. And it's not their appearance in the arterial phase which is helpful, it's their rapid washout, leading to a very black hole which is often present in the liver even before 1 minute. So let's look at 3 different patients in the arterial phase. So all of these patients have metastatic lesions. They bear no similarity to each other, and of course there's even many other patterns. So the patterns are non-discriminatory and highly variable as above. Now, let's look at a very good patient. So this was a patient with a remote history of breast cancer who came to the emergency with flank pain. And so while she was having a scan, on a CT scan, it was noticed that she had a mass in her liver, which wasn't characterized. So when we look at this patient, this case is a beautiful example of another ultrasound rule. We don't want to do her contrast on the supine position because of the depth of that lesion from the transducer surface. But on the right image, we can see that when we place the patient in left lateral decubitus position and come intercostally, that we can see this lesion only at half the depth of its original space. So that is where we will position the patient to do the contrast injection. So when we inject the contrast, you can see instantly the mass is hypervascular, instantly, even before there's any contrast in the liver. And now, as the liver is enhancing normally, 26, 27 seconds, the liver is now lovely enhanced, and you can see that the mass has already completely washed out. And so the transient hypervascularity is not evident. And this explains, of course, the discordance that's shown in the arterial phase, often for metastatic lesions. So when we look at this patient, we see the baseline image on the left. The central image is the arterial phase uniformly hyper-enhanced mass, and by well under 1 minute, the lesion has already become a black hole in the liver. So very confidently, we can suggest that this is likely to be a malignant lesion. We're very suspicious and recommend a biopsy. And so this biopsy shows unsuspected metastatic carcinoid tumor. Now, pearl number 5 and pearl number 6 are related to each other. So contrast-enhanced ultrasound in the portal venous phase obviously will improve the detection of metastases over baseline, in that it improves the conspicuity of the lesions, and therefore we will see both more and smaller lesions on CEUS than we will see on baseline ultrasound. Now, in a study that Peter Burns and I participated in with the Europeans way back around 2000, this is the publication which I cite. In this publication, we had several hundred patients, and we had results that were equivalent to CT scan and superior in some circumstances in looking at metastases in patients with CEUS. And so, pearl number 6 follows this. We always try to perform portal venous phase sweeping of the liver, and what are we doing? We're looking for washout lesions. So this is the optimal time and the technique for detection of liver metastases. So this is my most shocking example ever, and I've had this for a long time. Some of you will have seen it before, and so the reason I still use this same case is because this is the best case ever, and I don't see this every day. This is infrequent, but I show it to you for impact. So this patient came to our emergency department with abdominal pain, and one of my colleagues called this liver normal on ultrasound. And so when I look at this picture, I think, you know, that's a pretty good call. It looks pretty normal to me too. So what happened was the patient was taken to the operating room for emergency surgery because they thought his abdominal pain was related to a leaking aortic aneurysm. And it was the anesthetist who phoned me and said, "Stephanie, can you come with your machine and those bubbles to the operating room? I would like you to look at this liver before I anesthetize this patient." So we trundled off to the operating room, and there's the injection of contrast, and you can see that this liver has got multiple lesions in the liver, and when we sweep in the portal venous phase, you can see the tremendously increased conspicuity. So I showed that for effect. Thank heavens this does not happen daily, weekly, or even monthly, but it can happen. So the timing of washout is discriminatory. So metastases, as we've shown, wash out very fast, often within the time frame of the arterial phase, and they tend to wash out completely. So let's look at a patient with breast cancer. So we can see on the baseline scan a very hypoechoic mass in the liver. Now the low MI image, interestingly, for those of you doing contrast, oftentimes we show additional lesions as here, where we can see different lesions just with pulse inversion imaging. But so the first images that I will show you here show that dominant mass with increasing enhancement. So both the liver and the lesion are increasing in enhancement up to around 22 seconds. However, from here, we now start to have decline. So we have to judge washout relative to the level of enhancement that the lesion acquired in the arterial phase, but this lesion washes out. And of course, in the portal venous phase, when we would be sweeping the liver, you can see that the conspicuity would be greatest and we would detect the largest numbers of lesions. So this was a case that was in Peter Burns and my very first series of patients that we scanned when we looked at 176 patients with contrast ultrasound compared to CT or MR scan. So all patients had an unenhanced scan and then a contrast enhanced scan. So when you look at these two baseline images, they're both quite horrid actually, but you can see that the ability of ultrasound to resolve lesions is obviously far superior to CT scan, which depends on contrast to increase contrast conspicuity in the liver. And so I'd like to suggest to you that nobody would interpret that CT scan with contrast. And certainly, I would like to suggest to you also that nobody should interpret that ultrasound scan without contrast either. And I think Deb Rubens was really wonderful to us in her presentation. She made that point over and over that contrast really helps. So there's this patient on their baseline scan, and then here they are at the portal venous phase showing this peak of difference between the multiple metastatic tumors that really riddle this liver and the background parenchyma. And so my conclusion from this many, many years ago was really that both CT and MR and ultrasound require contrast agents for detection and characterization of liver masses. So what about pearl number 7? Well, so malignant tumors show washout. We've been discussing that. And so the timing and the intensity of the washout are discriminatory on CEUS. So on MR and CT scan, we tend to document the presence of washout. And on CEUS, we want to document the presence of washout, its timing, and its intensity. And so what are our objectives? Well, we know that hepatocellular carcinoma is characterized by weak and late washout, and that non-hepatocellular malignancy, by comparison, has early and marked washout, as we've just been looking at on those metastatic lesions. So if we make a 2x2 table, we can see that the late and weak washout, we were thinking of HCC, whereas the early and marked washout, we're thinking of metastatic lesions and other non-hepatocellular malignancy. And what do we do with the lesions that come up in the other squares? Well, we're going to characterize them as suspicious for malignancy requiring further evaluation. So let's look at a patient who came to our emergency department with no risk factors that were known, and he had a mass found on his ultrasound that's hypoechoic, concerning looking, so we do contrast at that time. And you can see that we're showing a hypervascular mass. So as we've already said, we don't know for sure what this mass is. A hypervascular mass is characteristic of many different things when we see it in the arterial phase. So what do? We continue to look at the mass. So at 1 minute, this is a critical picture. This is the time difference between rapid and late washout. So at 1 minute, the lesion is invisible, so it's isovascular. And at 1.5 minutes, it's still invisible. We don't see it, so it's isovascular. So do we make the interpretation that the patient has sustained enhancement? Well, yes, they have sustained enhancement for 90 seconds. But what does this actually mean? Well, to avoid missing the diagnosis of hepatocellular carcinoma, we have to watch for a longer time. And with the contrast agent that I'm using, it's 5 minutes for sure. And so here we're still looking. You can see just before 4 minutes, is there vague, perhaps early washout on this lesion? And at 4.5 minutes, it's unquestionably there. And you can see that this is not a black punched out lesion. Rather, there are multiple bubbles which remain within the lesion. So this is weak washout at over 4 minutes. So what is this? This is a classic hepatocellular carcinoma, and this is confirmed in this patient by biopsy. Now, what about this patient, a 73-year-old male with a non-cirrhotic liver, but he's got hepatitis B viral carrier status. So we can see this lovely mass in his liver. When we do his contrast injection, you can appreciate that this robust technique lets us see the enhancement regardless of his respiration. So we confirm easily a hypervascular mass. At the peak of the arterial phase, a hypervascular mass. At 1 minute, sustained enhancement. At 2 minutes, sustained enhancement. But at 3 minutes, our intermittent scans to preserve the bubble population allows us to show weak, late washout, a classic HCC. So pearl number 8, non-hepatocellular malignancy often shows rim enhancement and rapid and marked washout, similar to metastatic disease. So here's an 82-year-old female, not with risk factors. She has mid-abdominal pain and a very large mass in her liver. We can see surface retraction with much greater difficulty on ultrasound than on CT and MR scan, but well shown here. And when we do the contrast-enhanced injection, you can see that we're looking at a rim-enhancing lesion with a relatively hypovascular center, so definitely big rim on this lesion. And when we look at our subsequent imaging, by 47 seconds, we can see that that rim is disappearing, so there's rapid washout, which becomes more marked by 1.5 minutes. So what will we suggest? Looking at the later images, even more striking marked washout, and you can see multiple satellite lesions on our sweeps through her liver. So what do we suggest? Non-hepatocellular malignancy, and the patient has biopsy with peripheral cholangiocarcinoma. So pearl number 9, microbubble contrast agents are purely intravascular, so the contrast agent for CT and MR scan by comparison has a well-recognized interstitial phase, which is especially evident in malignant tumors with permeable endothelium and fibrous center. So the result is that washout is correctly shown in the portal venous and late phase on CEUS for a malignant lesion, whereas CT and MR scan can show sustained or even increasing enhancement in the portal venous and late phase. And when does this happen? Well, especially in non-hepatocellular malignancy, and in our at-risk population, we're always suspicious for cholangiocarcinoma. So let's look at such a patient. This is a young man who has a mass in his liver, which is heterogeneous and enhancing in the arterial phase on CT, with increased enhancement in the portal venous phase, indeterminate result. So this patient goes on to have MR scan, which shows the same observations, so an indeterminate CT and MR scan. When the patient comes for ultrasound, the arterial phase is identical with heterogeneous hyperenhancement, and in the portal venous phase, complete rapid washout. So malignant on CEUS, and biopsy in this 29-year-old male shows cholangiohepatoma. And so why do we have this discordance with ultrasound showing washout and CT and MR showing increased enhancement amount and intensity? So this is related to the purely intravascular bubbles on CEUS shown at the top, and related to interstitial leakage showing pseudo-enhancement on CT and MR scan. So I'll just skip that. Now, so the ultrasound pearls that I've shown you are all reproduced in my syllabus, and if you're interested, they're there, and I'm just going through them right here. And so in the interest of time, I won't repeat them, but I believe if you understand all of those things, you'll do exemplary. Peter Burns and I made a mistake on everything when we were starting, trying to wrap out all of these rules. And so I hope that my sharing them with you will be helpful. So what do I believe? CEUS is obviously an excellent modality for characterization and detection of focal liver masses. And although it has excellent agreement with CT and MR scan, the instances when there is discordance show the advantages of purely intravascular microbubble contrast agents. Thank you for your attention.